Before we can begin this podcast, I would like to take a moment to acknowledge the awful hate crime which occurred at the Tree of Life Synagogue in Pittsburgh this past weekend. As you all know, we record this podcast at the Children's Hospital of Pittsburgh, which is 3 miles from the Tree of Life Synagogue. That Squirrel Hill community is also where I first moved when I moved to Pittsburgh, and just a wonderful place to live. To our friends, neighbors, colleagues, or anyone affected by this awful tragedy, we are here to support you, we love you, and our thoughts and our prayers are with you. Right now we are mourning, but we are united in saying that we reject this or any type of hatred, bigotry, and violence. This was recorded after the podcast you're about to hear. The podcast you're about to hear was recorded prior to this weekend. Now I'm going to put you right into the beginning of the podcast on Enterovirus D68 and AFM with Dr. John Williams and I. Thank you for listening.
This podcast is for general informational, educational purposes only and is not to be considered medical advice for any particular patient. Clinicians must rely on their own informed clinical judgments when making recommendations for their patients.
Hello, everyone, and welcome to another installment in our Pediatric Hospital Medicine podcast series. We are on episode number 16, coming to you from UPMC Children's Hospital of Pittsburgh. We are back in my office. My name, in case you don't know, is Dr. Tony Tarchichi. I'm a Med-Peds trained pediatric hospitalist here at UPMC Children's Hospital of Pittsburgh in the Paul C. Gaffney Division of Pediatric Hospital Medicine. We've been doing these podcasts. This is a special episode. I'm fortunate enough to have as my guest Dr. John Williams, again, friend of the podcast. He is the chief of the Pediatric Infectious Disease Division here at UPMC Children's Hospital of Pittsburgh and a professor of pediatrics in the University of Pittsburgh School of Medicine. John, thank you very much for joining us.
Tony, glad to be with you. Thanks for having me.
Why don't we do our disclaimers and get them out of the way? I'll start. I have nothing to disclose.
I serve as a consultant on the Scientific Advisory Board of Quidel, and I serve on a Data Safety Monitoring Board for GlaxoSmithKline, neither of which has any relation to what we're going to talk about today.
All right, great. So the topic that brings us here today is, and I'll tell you how, everyone, if you're listening, how it got started. About a month and a half ago, I started noticing a lot of kids coming in that I was taking care of with asthma exacerbation, significant respiratory distress, kids that haven't had asthma flare-ups in years. And it really reminded me of 2014 when we had the Enterovirus D68 outbreak. And I started asking, are we having it again? So then I emailed a person who I knew would know the answer, John, and he got back to me and said, yeah, your hunch is right. Now, John, is this right? So we saw a real big uptick in Entero D68 again, triggering a lot of these asthma exacerbations.
Yeah, it's really interesting, Tony, because as you say, in 2014, there was a large national outbreak, and it was really distinctive that everybody was seeing these older kids, either who hadn't had a flare in years or kids who had no history of asthma, but came in wheezing like an asthma exacerbation at 8, 10, 12 years old. That's very unusual. And then there was a little EVD68 in 2015, but not much. There was a bit of a surge in there was very little in 2015, somewhat of a surge in 2016, very little in 2017, and then a big surge this year. And the reason I knew that is that Marian Michaels and I have a CDC-funded surveillance study where we recruit kids in the hospital and in the emergency department in the ED with acute respiratory illness or acute gastroenteritis. So we can do a lot more specialized testing than the hospital lab can. And over the last 2 months, about 25% to 30% of all the kids with acute respiratory illness had EVD68. That's extraordinarily high. Like during the peak of RSV or the peak of flu, those are the kind of numbers we see.
So the first question I have, which seems to be the most glaring, is why did this really pop back up? And why did this pop up in 2014? Do we know if the virus changed or what happened?
I'm sorry, next question. These are great but difficult questions. EVD 68 was actually discovered in 1959, so it's been known for a long time. And like many enteroviruses, it would cause sporadic illness here and there. We don't really know why the 2014 epidemic was so large. We do know people have taken those 2014 viruses from humans and compared them to sort of the old EVD 68 viruses in cells and in mice, and they behave differently. So that's one thing, is that 2014 and the more recent viruses are different. They sort of evolved a little bit, if you will. And in terms of the every 2 years, this is something that people have described for other enteroviruses, and in fact for other respiratory viruses, that you'll see sort of these every other year peaks of viruses. Karen Hall, the late, great Karen Hall from University of Rochester, described this decades ago for parainfluenza 1 and 2. You'd have a big year of paraflu 1, and then the next year would be a big year of paraflu 2. As clinicians, we just say, well, there's a lot of croup around, and we don't know which virus it is. It's thought, but not proven, that the reason for this is you get a big epidemic of a virus like EVD 68, and then a lot of people are exposed, and a lot of people are somewhat immune. And so next year you don't see as much. And then that immunity kind of wanes, and then the virus can reinfect. So this pattern is somewhat unusual, but it's been described for other viruses.
Now, what I know of enteroviruses in general, traditionally it's taught that they're passed by fecal-oral route. You have a hand, foot, and mouth outbreak or something. That's how it's passed. Am I right that this virus somehow is now passed otherwise in respiratory droplets?
Yeah, that's exactly correct, honey. So EVD 68 is much more easily passed through respiratory droplets for reasons that aren't totally clear. I mean, it probably has something to do with the receptor targeted by the virus, and that receptor may be more prevalent in the respiratory tract. We, as clinicians, we sort of lump this whole family together and we say enteroviruses, but there's over 100, and it includes the Coxsackie A and the Coxsackie B and the echoviruses. And we think of them all together, but they're really quite different in terms of what they can do to the host in terms of disease, and in this case, how it gets in. So that is a difference with enterovirus 68.
Do we know why it seems to really go after these kids with asthma or even just a propensity to wheeze and really causes distress? Is there something different about them, or are we not sure?
We do think it's the virus. We don't know for sure, but a number of groups have taken these new strains of virus of EVD 68 and the old classic sort of strains of EVD 68 and put them into cells in a lab. And what you see is that the recent EVD 68 stimulates a very different immune response than the old virus. What really is not clear, I think, is why would the virus, quote unquote, want to do that? So these viruses have an RNA genome, and RNA viruses mutate a lot. Flu mutates a lot. This is why we need a new flu vaccine every year. HIV, Hep C, these mutate a lot. That's why they're so hard to make a vaccine for and hard for the host to control. So RNA viruses mutate kind of for a living, but why? What is the advantage for the virus of causing more respiratory disease? We don't really know.
In the ID community, are you all expecting this to continue every couple of years? So for PICU staffing, for hospitalist staffing, should we expect this?
You really wouldn't expect it, Tony, because historically, if you look at different enteroviruses, you'll see these big community outbreaks, and then they can occur for a while, but then they sort of fade away and they're replaced by different enteroviruses. So, we all see lots of enteroviruses every year. Hand, foot, and mouth, aseptic meningitis, non-specific febrile illness. When all of us see kids with a fever and no other symptoms, an enormous number of those are enteroviruses. But if we really typed all those enteroviruses, we'd be seeing sort of a sea of different enteroviruses. And so we would not, based on other enteroviruses, expect to keep seeing EVD 68 every couple of years from here on out. We would expect that in a couple of years it would sort of fade away and, enterovirus 53 would take its place.
And is the outbreak done? Are we seeing the levels die down?
We do think it's died down. I think there are fewer positives in the hospital lab. There are fewer positives in the research study that Marion Michaels and I do. That would fit with all enteroviruses. 95% of enterovirus infections are between June and September. And in fact, we're mid-October, it's starting to get cold. We don't really know why enteroviruses cluster in the summer like that, but they do. And so, yeah, we're kind of getting out of that season, and we have a brief lull before RSV season.
Right. And that's it. In 2014, we went right from August to like January, and then went right into RSV season. Is that right?
Yeah, that was really a big year for 2014. I mean, that was, I think, I've talked to friends around the country who are part of this research network that Marion and I are. They're also seeing a lot of D68 respiratory disease. So you're not hearing a ton about it on the news, but probably all of your listeners are seeing it in their hospitals, whether they're able to test for it or not. But I think everybody I've talked to at the other sites, it's fading away or gone. So I don't think we're going to see it continue until December, January.
Well, that's good.
Yeah.
Now, it's hard to talk about Enterovirus D68 and not talk about something that's been in the news a lot, which is acute flaccid myelitis, because they seem to increase at the same time this year. And for those of you listening, there is Children's Hospital of Pittsburgh has started a second podcast, of which John is one of the hosts, called That's Pediatrics. And one of their most recent episode was on acute flaccid myelitis with John and Dr. Carolyn Coyne, who's a researcher in enterovirus virologist here at Children's, and then Dr. Brian Martin, the VP of Medical Affairs, which I listened to prepare for this, which was a really nice episode. So thank you for doing that. But can we start with let's just start with the definition of acute flaccid myelitis.
Yeah, so acute flaccid myelitis is, as it sounds, acute. The onset is usually in a couple of days. And it's flaccid, meaning that the limb affected has diminished or absent deep tendon reflexes. So this is an areflexic weakness or paralysis. And it's usually asymmetric, so it often affects one arm or leg or one side more than the other, but it can affect all arms and legs. And the myelitis is because on MRI, one should see T2 hyperintensity of the gray matter of typically the cervical cord, but of the spinal cord. So, a lot of things can cause weakness or paralysis in kids that's symmetric or asymmetric. But a lot of those, affect the white matter. So acute demyelinating encephalomyelitis, which is an MS-like condition, or some of the autoimmune encephalitis syndromes. But this, like polio, affects the anterior horn motor neurons, and you see typically only gray matter involvement. So the MRI is kind of an important diagnostic criterion to say this is AFM and not one of those other things.
So now I'm a hospitalist. I'm in a community hospital. If I see a kid who comes in with weakness, we're saying one arm or one leg, usually unilateral, for a couple of days, there's typically pain associated with enterovirus-induced AFN? Is that right?
There's usually not. There can be sensory involvement, but most of the time there's not pain.
And any hypo or hyperreflexia you would see?
Hyporeflexic. They typically would be hyporeflexic.
So they're coming in with unilateral weakness. Maybe they're hyporeflexic. One of my thoughts is maybe this is one of the kids I'm thinking about with AFM. So my next step is a spinal MRI with contrast, looking for enhancement of the anterior horn. Is that right?
Yeah, of the gray matter. And then the next step would be an LP, a lumbar puncture.
And with that, is it what I understand, and correct me if I'm wrong, you get some non-specific findings. You'll have a leukocytosis or an increase in white blood cell count. Did you get anything else?
No, typically in the spinal fluid of most cases of AFM, there will be a pleocytosis that may have some polys, but usually has a lot of lymphs and monos as well, and a normal glucose, and it may have an elevated protein. It's usually not markedly elevated, and a negative gram stain. So it's typical for what one would describe as an aseptic meningitis.
Would you, if you have the secondary to an enterovirus, would you get enterovirus PCR positive from the CSF?
Possibly. So the best way to diagnose an enterovirus as causing this is to do PCR on both a nasopharyngeal swab and a throat swab and the CSF. and stool. And actually, the CDC, and for any of your listeners that have a case of suspected AFM, the CDC has a national study going on. They have this very well laid out on the website. If somebody Googles CDC AFM, they'll hit it. And in addition to their own hospital testing, they can send a nasopharyngeal swab, serum, CSF, and stool to the CDC, and the CDC will do all this PCR testing on all those samples and get the results back to the facility, usually within a couple of weeks. It's pretty quick.
What's the prognosis for these patients?
Well, it's difficult because some kids, will make a complete and full recovery, but that's a minority of kids. So about 3/4 of kids are going to be left with some neurologic sequelae, which could be weakness of the affected limb to, in really severe cases, it could be complete paralysis of legs and or arms. There are some patients who are left ventilator dependent, who need a tracheostomy, and who need a feeding tube. But it typically does not affect the brain, so their mentation is totally intact. It's usually not encephalitis.
That's interesting. And from what I understand, the only thing we can do in terms of treatment is supportive care. So if they're having trouble, get them in an ICU, that kind of.
Yeah, the only thing really, there's nothing definitive. So a couple of points on that. One is just so that people think of other things. When they see a patient with acute flaccid myelitis, in terms of viruses, there's a very short list of viruses that can cause an asymmetric flaccid paralysis. Enteroviruses, West Nile virus, rabies, and a virus that you would only see in a traveler called Japanese encephalitis virus, sort of a cousin of West Nile. So history is really important because if the patient had mosquito bites, you would think about West Nile. In the current national cases of AFM that the CDC has tested, none are West Nile. And rabies, obviously that's very important history to take of was the child exposed to a bat or a skunk or some kind of animal, because there the treatment would be very, very different. But if you determine this child has AFM, you suspect it's an enterovirus because there's no history to make you think of rabies. It's primarily supportive care, respiratory, nutrition, hydration. Now, there are a number of things that people often try. So people will often use IVIG as an immunomodulator. The CDC does not endorse that because there's no evidence for benefit. People sometimes try steroids as an immunomodulator. The CDC discourages that because that has been associated in cases of AFM in Asia with worse outcomes, because you're suppressing the immune response, and that makes it harder to clear the virus. Some people have tried plasmapheresis, plasma exchange. The CDC discourages that because there's zero evidence for benefit, and obviously that's a pretty invasive, procedure. And then the final thing that you'll see in the literature is fluoxetine, a selective serotonin release inhibitor. The short version is that drug, fluoxetine, has some in vitro activity in cells in a dish against enteroviruses, specifically against EVD68. However, the level of drug that you need in the dish to do that is far higher than what you get in the blood of a human treated with Prozac, with fluoxetine. And there's no data for that. So the CDC also does not endorse that because there are potentially significant side effects and no evidence for benefit. So yes, that's the long version to say supportive care is the only prudence.
And one of the things you said is that no West Nile virus has been related to an AFM case.
In this year.
Yeah. What have we found has been related to the case this year?
Yeah, this year, what the CDC has found and other sites are some EVD68, some other enteroviruses. There's another enterovirus that particularly targets the nervous system called EVA71 or EV71. There was a cluster of those described in Colorado, in Denver earlier this year. Other enteroviruses, such as Coxsackie A viruses.
So a few of them have been caught.
Yeah. And in previous years, we've only been really tracking AFM closely since 2014. But by now, a lot of cases have been reported and tested. And a virus is found in only about 20% or so of all these cases. But of the viruses found, the most common are enteroviruses.
So in 80%, we simply don't know, even though we're testing.
Correct. Now, in most cases of AFM that really fit this definition in children that we described, so we're not talking about somebody who's had weakness in the arm for a month or, altered mental status or things like that, the majority of the kids had an antecedent illness in the month before, either a respiratory or a gastrointestinal illness. And so that's what makes people think that a lot of these probably are caused by enteroviruses. But the places we can look, the respiratory tract, the intestinal tract, and the tools we have, which are viral PCR, are just not good enough. And so what is thought, and I personally believe this, I think it's accurate, is that we're just late to detect the virus. By the time the child presents with AFM, the virus is going away. They've been infected for a couple of weeks, and the amount of virus is relatively low. And clinically, we don't routinely test people's stool for viruses. In fact, most hospital labs would not do that. But the CDC can. That's the best chance to make a diagnosis because the kids with enterovirus will often shed at the stool for many weeks.
Now, we've been tracking AFM now for 4 years. Are there other places in the world that see this more often than we do? Not polio-related, the enterovirus ones.
Well, that is a great point. I think everybody's just got to keep in perspective because there's obviously a lot of concern about AFM because I think it really is a new problem. We've only been tracking it since 2014, but the world is small, and I think those of us in pediatrics would have known if we were seeing 150 cases of AFM in 2012. So I really think it is new, but and again, even though we often don't find a virus in everybody, if you look at the peak of AFM and the peak of D68, there's a very strong correlation there. So 120 cases in 2014, a couple of dozen in 2015, 150 cases in 2016, a couple of dozen in 2017, and we're on target for another 120 to 150 probably this year when it's said and done. I mean, just to put that in perspective, since you mentioned polio, in the 1950s, right here in Pittsburgh, there would have been hundreds of cases. In 1957, there were about 25,000 cases in the U.S. of paralytic polio, and the pediatric population was much smaller. So I do think we have to remember this is scary and serious, but it's a tiny fraction of what our forebears would have seen as pediatricians 50 years ago. In the rest of the world, non-polio. Now, a lot of places in the world are doing active AFM, or in most places they call it acute flaccid paralysis, AFP surveillance, because of the polio eradication effort. Polio is now in only 3 countries in the world, so it's on its way to being eradicated. They see some AFM everywhere, but the only places, notably in the last 5 years or so, that have seen a lot is throughout Southeast Asia related to EV71. There's been a lot of AFM and encephalitis caused by EV71 in that part of the world.
So they've seen a lot more than we have due to that. And they have a vaccine, from what I understand.
Correct, yeah. There's a vaccine. It's either in China and or Japan, but it's been serum enough. They've had kind of an ongoing countrywide endemic sort of circulation that has evolved over the aggregate of the last decade, millions of kids.
So is it too early for us in the U.S. to begin thinking about creating a vaccine for this? Or are efforts already underway that we just don't know about?
Yeah, there are people working on sort of early preclinical things where you try something in a lab, usually in a mouse model, to see if the mouse will make some antibodies. I think, the problems are, one is that we don't know for sure what the virus is going to do, whether it's really going to continue and spread. I mean, if Enterovirus 71 does here what it's done in Southeast Asia, then yeah, we'd be looking at millions of cases and a vaccine would be great. But of course, we don't know it's going to do that. We don't know if there's some genetic differences. The other real challenge is, and this is a good point just about vaccines in general, but for all the pediatricians of us who are thinking about this and listening, vaccines are really a thankless sacrifice for pharma, for drug companies. Some people think, oh, those drug companies just want to make all their money on the vaccines. Okay, so vaccines are 2% of their portfolio. 2%. All the companies making vaccines could drop them tomorrow and they wouldn't notice. And I think all pediatricians are familiar with the challenges of getting a vaccine to market in terms of safety and clinical trials. It's way easier to come up with Viagra 2 and make $12 billion a year than to develop a new vaccine. So should we as scientists and a society and as pharma be thinking about and at least trying to develop vaccines? Yes. But there's not many efforts in that region, in that direction.
Oh, that's I didn't know that, so thank you for telling me that. It's really, those are the questions I was worried about for this Enterovirus D68 and AFM. And I promised to have you on the podcast not when there's an outbreak or something. Last time we had you on when there was flu, and now this. Is there anything I didn't ask that you want to let our audience know?
Well, I think it just shows, how little we know about these viruses and yet how interesting they are. So polio is actually in the enterovirus family. So we often call the others the non-polio enteroviruses. And it's been known for decades that non-polio enteroviruses can cause a paralysis like polio. In fact, I saw a case myself as a resident 25 years ago of a young child who had paralysis of one leg and grew an enterovirus out of his stool. Back then, we didn't type them, so we didn't know what it was. But we knew it wasn't polio. And we know that none of the current cases are polio. So, if we really understood why do some viruses in this family have a much greater capacity to cause this kind of disease and others do not. If we understood that, then we could say, maybe EVD68 and, EV53, maybe those are the only two we need a vaccine for because the others so rarely cause paralysis. We have a vaccine for HIP, right? Haemophilus influenza type B. There are other types of Haemophilus that are encapsulated and cause invasive disease, A through F. But they're so rare that it wasn't worth making a vaccine. So when people learned, hey, it's not all Haemophilus influenza, it's just HIP. It's just that one. Okay, that makes it a lot easier to make a vaccine. So, there's over 100 enteroviruses. That's very tough for a vaccine. But if we could learn, there's really only 3 that commonly cause AFM. Then we could develop, a trivalent enterovirus vaccine. We could make it just like Jonas Salk's polio vaccine, invented right here at the University of Pittsburgh. He laid out a beautiful blueprint. So if we knew which enteroviruses we wanted to target, I think we could do exactly what he did, and I think it's very likely it would work.
And the scary part from a pediatric perspective is thinking to myself and other colleagues that are we headed back to the era of polio being or polio-like illness being as prevalent as it once was, which is really 2 generations of physicians ago from where I'm sitting. And more efforts like what you're discussing of really isolating which enterovirus is causing these issues, getting a vaccine would be really appreciated because I'd like not to relive that era as a practicing hospitalist or a pediatrician in general.
Oh, my God. Yeah, I've talked to physicians who did practice in that era. Like you, I'm not that old either, but, and when you hear their stories and you see the pictures of the iron lungs and, we had an older pulmonary doctor. I spent many years at Vanderbilt, one of our older pulmonary docs there. had an old iron lung that he sort of kept down in the basement as like a memento of like never again in those days. And, you know, we've been fortunate that in our career, we haven't dealt with polio. You know, for me, I saw sort of the tail end of HIV. Mm-hmm. I've seen invasive pneumococcal disease, you know, dramatically be reduced. Vaccine came out several years after my residency, so that's dramatically reduced. Perinatally acquired HIV, almost gone. Mm-hmm. Rotavirus vaccine. So in our career, we've, you know, seen dramatic advances all due to vaccines. And I think the challenge is both being vigilant of new diseases that arise, like these AFM cases, and figuring out, is that something we need to target for vaccines? And then, of course, as pediatricians, we all know this, like helping the public stay vigilant. You know, like, because people think, well, I don't really know if my child needs these vaccines, you know, because I haven't heard of anybody with meningitis. Yeah, that's because of the vaccines. So please give your kid a shot.
And that's hard. And I think at PHM 2 years ago, we had someone present who isn't a physician, but was a neurobiologist, I believe, who talked about how people make decisions and really discussed when people label themselves in a certain label, like anti-vaccinator. All the information in the world is going to move them. And we've seen that, where we talk to patients who don't want to vaccinate, give them information, and it just doesn't help. So it's a challenging dilemma, the one that we'll continue to try to fight. But thank you very much. I want to say thank you to Dr. John Williams for being on today. This was a special episode on Enterovirus D68, the respiratory outbreak, and we talked a little bit about AFM. Again, if you want more, or AFP, if you want to be proper about it. If you want more information, please listen to That's Pediatrics from the UPMC Children's Hospital, Pittsburgh, where Dr. Williams talks about it, with Dr. Carolyn Coyne, an enterovirus virologist for a number of years, and Dr. Brian Martin. This was our special episode. I'm going to have another one coming up in the next few weeks, probably on Lyme disease and then on vascular anomalies for the hospitalists. So thank you all very much for tuning in. As always, I want to say thank you to Dr. Megan Keene Tarchichi, who helps me with everything, and Paul C. Gaffney, Division of Pediatric Hospital Medicine, for continuing to allow me to do this, and UPMC Children's Hospital, Pittsburgh. So thank you, everyone. John, thank you very much for being on.
Thanks for having me, Tony.
If you have any suggestions or comments for a podcast, compliments, or anything, please feel free to email me at tony.tarchichi, TARCHICHI, @chp.edu. We'll see you next time. Thank you.